So we're going to talk about coronary artery disease and heart failure today. So welcome to all our incoming fellows and the current fellows. We're going to start with a case, and I'm going to give you guys a poll to see what you guys think about it. It's a 53-year-old man with history of diabetes, hypertension, dyslipidemia, tobacco abuse, chronic kidney disease stage 3, history of PCI to RCA in October of 2018 when he presented with STEMI, and he takes aspirin and Brilinta. He has ischemic cardiomyopathy with EF severely depressed and an apical thrombus. He is getting recurrently admitted with acute decompensated heart failure, more so because of dietary and some medication non-compliance, but no angina. In December of last year, he presented with STEMI and an acute decompensated heart failure. He became quickly chest pain free with decongestive therapy. His transthoracic echocardiogram shows moderately enlarged LV size, severely depressed EF with akinetic apical inferior infralateral segments. So he's taken for left heart cath, and his cath shows normal left vein, circumflex, which is 100% occluded with a large size OM branch that has 70%, both of the branches have 70% stenosis. LAD itself has 70% stenosis at the level of second septal, after which there is diffuse disease. Septal branches of the LAD give some collaterals to the right side. RCA is 100% in the proximal portion. Stents are seen in the distal RCA, and some bridging collaterals are supplying the distal RCA. So what is going to be, what are you guys going to do? There is a poll in progress, if you can click on it. So a third of you want to do stress test viability evaluation. A third of you think he's advanced enough for evaluation for advanced therapies, and 1/4 thinks that he should be evaluated for CABG. Okay. Objectives of our talk for this purpose is going to be recognize CAD as an evolving #1 risk factor for heart failure. We'll talk about diagnostic testing for CAD in heart failure, risk stratification, guideline-directed medical therapy, role of revascularization, and we'll touch upon device therapy. What we will not be able to cover in detail, but what you guys should look into is that these guys, because we are talking about the topic of CAD in heart failure, there is a whole bunch of guidelines about stable ischemic heart disease, valvular heart disease. We will not be able to touch upon great detail upon heart failure with preserved EF and the valvular guidelines. Over the past 40 years or so, the odds of previous MI as a cause of heart failure has been steadily increasing, 26% per decade in men and 48% per decade in women. And there has been a steady decrease for hypertension as the #1 risk factor for heart failure, 13% per decade in men and 25% per decade in women. And so is valvular heart disease, that is decreasing. This is a NEJM trial of and all the trials that have been published in NEJM with prevalence of CAD and over the past 20 years or so, and this accumulative is about 45,000 patients. And CAD is the underlying cause of heart failure in about 65% of these patients. And this is likely an underestimate because the true prevalence of the CAD among unselected heart failure patients is when they probably got excluded patients from angina, acute MI, and shock. And not many of these trials had done an objective ischemia evaluation. Recently done trial, the ischemia trial that enrolled about 5,000 patients, the prevalence of CAD by CT and CT scan was 79% multivessel disease and 87% had left anterior descending disease. These trials have also demonstrated prevalent CAD in heart failure preserved EF that we'll talk about a little bit later. So when we talk about how to see what is the pathophysiology of LVD modeling, right? We tend to think that the progression of heart failure is because LV is remodeling. And all the therapies that we have developed so far target that neurohormonal conditions to modulate the loading conditions and remodeling. So to prevent that and try to restore the geometry of the heart to improve the function. However, more and more we are realizing that the factors that initiate LV dysfunction, meaning coronary artery disease, hypertension, AFib, diabetes, valvular disease, they are as much responsible for leading to heart failure than LV dysfunction itself. So the presence and extent of coronary artery disease in these patients accelerate the progression of heart failure. This explains the higher mortality that the patients have among ischemic cohorts versus non-ischemic cohorts. And there are a variety of factors in it. They all have elevated filling pressures, secondary to diastolic dysfunction, whether or not they have normal systolic function. Pulmonary hypertension, the secondary that develops, and the valvular disease. So what is the presence of CAD in these patients has been shown to be independently associated with worse long-term outcomes in numerous studies. Ischemia produces a rapid and massive increases in the concentration of endogenous catecholamines in these patients. So hence, even if the patient is not actively ischemic, the chronic ischemia that becomes an underlying substrate leads to deleterious effects on cardiac myocytes, leading to apoptosis, fibrosis. And LV systolic dysfunction without an obvious clinical ischemic event, right? So another complication, now the chronic ischemia may result in stunning and hibernation of the patient's endothelial dysfunction. And another problem with remodeling is mitral regurgitation. And the secondary MR, even if in a milder degree, is an independent predictor of long-term mortality in these patients. So how do we proceed with testing in this cohort? If you look at the guidelines, they become quite cumbersome with class 1 recommendation, class 2 recommendation, and all that. So for the fellows to easily remember, this table is from the appropriate use criteria. So whereas when we go to the guidelines, we know class 1 guidelines, class 2, A and 2B, and class 3. For the purposes of the boards, usually it's the class 1 and the class 3 guidelines that are more important, but as you evolve and become more subspecialized, you will get more questions on class 2 guidelines as well. So we all know class 1 guidelines are that have strong recommendation, we should do these things. And we know that the class 3 guidelines are the things we should stay away from and do not do that. Class 2A and 2B become a little bit tricky. 2A are the guidelines we can consider doing, and 2B are the guidelines are not a soft consideration. So it is easier to focus if, when we think of these patients, when we are evaluating patients with coronary artery disease and heart failure, is to think if they have angina or they don't have angina. So if the patient has active chest pain, then it's a class 1 recommendation to do a left heart catheterization. Now, if the patient has chest pain and they have heart failure, then whether we know their anatomy from before or not, we could take them to the cath lab. It is reasonable to do that. And it's a class 2B recommendation to do a non-invasive imaging to define the likelihood of CAD in patients with heart failure who have LV dysfunction. Now, if the patient has no chest pain or patients have atypical chest pain, then it's reasonable, and we suspect that they have CAD as a cause of it, then it is reasonable to do an evaluation either with a stress test or with coronary angiography. Okay, and if the patients have atypical chest pain and they present with heart failure, then it becomes a class 2B indication. So the marks here, the take-home point here is A means appropriate, M means maybe, rare, and rarely done. So I think what is important to remember is that if the patients have angina and they have heart failure and you want to do something, then just the rest testing is really appropriate, and you have to select some kind of a stress modality. If the patients can exercise and their EKG is interpretable, then you should always select a exercise stress modality than anything else. Similar thing when we talk about viability evaluation, right? So it's the same concept. If there is severely reduced LVEF, less than 30%, then it is appropriate to do some kind of a rest and a stress imaging. If the patients have mild ventricular dysfunction, then you have to be careful in what you're picking up as your testing evaluation for viability. But taking them just for the purpose of viability evaluation, taking them straight to cath is really appropriate. When we talk about viability and we talk about CAD in heart failure, one of the landmark trials that all of us need to know about is STITCH trial, surgical treatments in ischemic heart failure. We'll talk about the details of the trial a little bit, but since we're talking about viability, this is the STITCH viability hypothesis, where the randomized patients, about a little over 1,000 patients with myocardial viability versus no myocardial viability testing beforehand, and randomize them. What is important to realize here is that with or without viability, guideline directed medical therapy plus CABG, right? That was the original hypothesis. That it did not make much difference whether the patients had viability or they did not have viability testing done before, and till later on. And hence, if the patients were treated optimally with guideline directed medical therapy, CABG better versus medical therapy better, there is not much difference. But if they were treated better with medications, whether they had viability or not, it did not make much difference in the outcomes. So what did STITCH want to say? In patients who have heart failure, LV dysfunction, and coronary artery disease that is amenable to surgical revascularization, their hypothesis is that CABG, when added on to an intensive medical therapy, will decrease all-cause mortality compared to medical therapy alone. Inclusion criteria for the STITCH was LVEF less than 35%, coronary artery disease, suitable anatomy for revascularization with CABG. They should be eligible for medical therapy. So they excluded, meaning they don't have left main stenosis and they don't have life-limiting angina. Their exclusion criteria is acute MI, cardiogenic shock, if the patient is already scheduled for PCI, severe aortic valve disease, history of more than one prior CABG, and non-cardiac life-limiting illness. So if you see at the primary outcome, rate of death from any cause, medical therapy versus CABG, there was no difference. So they did not reach their primary outcome in 5 years of time. When you go to the secondary outcomes, you will see that the patients who had CABG had their earlier they had more problems, and this is a 30-day period, and this is understandable since they underwent a surgery. But if you go down here to the secondary outcomes, death from any cause of heart failure, cardiovascular causes, there was a signal that the CABG with medical therapy has more was probably more significant, and hence they led to a 10-year extension study to see this effect more in detail. So death from any cause, primary outcome, and death from cardiovascular causes. You can see that the CABG clearly had a cohort had a survival advantage over just medical therapy alone. So this is important, and hence how this is coming into guidelines for us is that CABG is indicated in any patients on guideline-directed medical therapy with angina and suitable cardiac anatomy, especially when they have significant left main or left main equivalent. That's a class 1 indication. What we need to pay attention to is these guidelines. This is how, if you look at the 2A guideline, CABG or medical therapy is reasonable to improve morbidity and mortality for patients with severe LV dysfunction, heart failure, and significant CAD. This is Stitch. And if we go down here, we can see here CABG may be considered in patients with ischemic heart disease, severe LV systolic dysfunction, and operable coronary artery, whether or not viable myocardium is present. This is class 2B indication. Now, this is also Stitch. Now, there are several other trials that I have not incorporated into the presentation just because of the time constraints, that have demonstrated that if patient has viable myocardium, more extensive their CAD, and better they are revascularized, they will have better outcomes. But this is the guidelines haven't really caught up to that yet. So in general, when we think about who to take to CABG versus versus just medical therapy alone, I think this is a useful slide to keep in mind, right? So if the patients have severe comorbid conditions, they have severe underlying kidney disease, severe underlying lung disease, they have their LVEF is a little bit better, so these are the patients who would probably do better with medical therapy. Whereas the patients who will survive better with CABG versus medical therapy, right? A little more sicker patients who have more ischemia demonstrated. And we will talk about how the mitral regurgitation or ischemic MR sets into that. A little talk about device therapy in heart failure. So when primary prevention, I think the class 1 guidelines are pretty straightforward for ICDs. If the patient had prior MI and their LVEF is less than 35%, they're functional class 2 to 3, and they have been it has been 40 days post MI with no recovery in LVEF, then it's a class 1 indication. If the EF was worse than this, but their functional class is better, they still qualify for having an ICD. If they had an event, a fatal arrhythmic event with VT or VFib, or you can induce it an EP study and their LVEF is less than 40%, it's still a class 1 indication, level of evidence B. For secondary prevention, it's pretty straightforward. Anybody who had a cardiac arrest from VFib, VT, and they have known CAD, then they are candidates for ICD. CRT guidelines become a little bit more tricky, and this is a helpful table to understand it in a little bit easier way. So if the patients have severely depressed EF and they are in sinus rhythm, look at the bottom of the slide. If they are class 3 or class 4 functional class and their QRS is more than 120, any morphology, they'll qualify for CRT. If the patients have a borderline QRS, meaning it is less than 150 milliseconds and it's a non-LBBB pattern, and they are not that sick, they're functional class 1 or 2, then it's a class 3. We cannot put CRT in those patients. If the patients had LBBB, of course, they'll qualify for CRT. If the patients had less than 30% less than 30% EF and they are ischemics, they still qualify for CRT. This is an easier way to understand the CRT guidelines in this population. So when we talk about ischemic MR, and we are just going to talk about ischemic mitral regurgitation here, we're not going to talk about primary MR. There are several pathophysiologies of MR, as we all know. Primary MR is with when there is a primary leaflet problem, for example, due to the valve prolapse, or due to a flail leaflet. Functional MR is the one that we are going to talk about for the sake of this talk, and this is secondary to ischemic myocardium, where the LV has ischemic or non-ischemic myocardium, where the LV has remodeled dilated left atrium and the dilated left ventricle that leads to annular dilatation. Tethered chordae and the leaflets, either because of ischemia, they have remodeled over time and dilatation, which leads to regurgitation. The guidelines that we're going to talk about have been updated from 2014 to now 2017 with some caveats. So mitral regurgitation with a secondary MR, when they have an underlying coronary artery disease, heart failure, the first thing to do is to treat them with guideline-directed medical therapy for secondary MR. We are not talking about primary MR. For secondary chronic MR, they must be treated with guideline-directed medical therapy. If they can tolerate it, they must be considered for CRT. And if they are still symptomatic with severe MR and they have persistent functional class 3 or 4 symptoms, then we can consider them for surgery. That's a class 2B recommendation. Anybody else who is asymptomatic after treatment with guideline-directed therapy and CRT, or even progressive MR, but with the reasonable functional class, the recommendation is only to do periodic monitoring. And we are going to come back a little bit more on it. So to talk about, and I'm going to touch base on the MR again, but to talk about guideline-directed medical therapy, since we have been saying that this is the way to go, what is the guideline-directed medical therapy? So diuretics are used just for decongestion, and loop diuretics are the diuretics of choice. We can add thiazide diuretics to it and to overcome the resistance. ACE inhibitors, ARBs, are the first line indication for all these patients. Beta blockers, aldosterone inhibitors. What I want you to pay attention to is, I don't know if you can see my cursor, in the aldosterone receptor antagonist treatment guideline, they are usually recommended for LV EF less than 35%. However, there is an exception if patients have an acute MI who have LV EF less than 40% and they have symptoms of heart failure or diabetes. That is also a class 1 indication. They have also made their way into heart failure with preserved EF for hypertension control. Other than that, then we go down to hydrolysine and isosorbide nitrate combination of therapies for African American population. Class 2A indication for other patients, and DIG comes with a class 2A indication. The role of anticoagulation is not recommended in patients with chronic heart failure with reduced EF without atrial fibrillation, without a prior thromboembolic event, without a cardiac embolic stroke. This is a class 3 indication. Do not do it if none of these are present in patients with heart failure with reduced EF. In fact, aspirin itself does not have a role in patients if they do not have coronary artery disease or another indication. Statins, just like that. Statins who have shown benefit in multiple cohorts over multiple years just for purely heart failure indication, statins do not have a role. Of course, if they have CAD, then they or another indication, then they should be on it. The point of all this is that when we even talked about STITCH trial and we talked about intensive medical therapy and mitral regurgitation, it's not only just to start the patients on these patients need to be up titrated very aggressively on this regimen of medications to see any benefit. And then they may not improve their LVEF all the way, but may settle down in mid-range LVEFs. But guideline-directed medical therapy remains the cornerstone of everything that we do in coronary artery disease and heart failure and across the other spectrums of heart failure. Now that we have talked about it, I'm going to come back to this chronic secondary MR issue, some of the guidelines that have been updated. So mitral valve surgery is reasonable for patients with chronic severe secondary MR, valve stage C and D, who are undergoing CABG or AVR. The guideline recommendation that has changed is right under it. It is reasonable to choose a chordal sparing mitral valve replacement over annuloplasty repair if operation is considered for severely symptomatic patients in functional class 3 or 4 with chronic severe ischemic MR and persistent symptoms despite guideline-directed medical therapy. This recommendation has been changed from level of evidence C to BR because of this randomized controlled trial that showed that mitral valve repair is associated with higher rate of recurrence of moderate to severe MR than that associated with mitral valve replacement in patients with severe symptomatic ischemic MR. So this is the change. The level of evidence has gone up. The other indications are repair or replacement for severely symptomatic patients with chronic severe MR who have persistent symptoms despite guideline-directed medical therapy. Another one that has been upgraded in level of evidence is chronic moderate ischemic MR undergoing CABG. Usefulness of mitral valve repair is uncertain. So in fact, they have also changed the recommendations for the area of regurgitant orifice based on this, because when the heart failure with reduced EF, with the prior guidelines, regurgitant orifice area that was considered moderate may still be severe because of the underlying LV dysfunction. So just for something to touch base on the valvular guidelines for this. I want to touch a little bit on it's a little bit stray away from the topic, but CAD in heart failure with preserved LVEF. And the reason for that is there are not many randomized controlled trials. This is an elegant study that was done by Mayo Clinic, in which they showed that the heart failure with preserved EF with CAD that is revascularized is do much better than heart failure with preserved EF with CAD incomplete or not vascularized. Also, depending upon their syntax score. Now, syntax score is, of course, a score that is calculated based on several things. Angiographic grading, it's an angiographic grading to determine the complexity of the coronary artery disease. And you can see all along here. And the whole purpose of putting this in this talk is that CAD, as we looked back in the epidemiology when we touched base on that, is it's a very significant risk factor. These patients will continue to decline their LVEF. So they, regardless of their LVEFs preserved right now, if they're not treated, then they'll continue to decline that. Now, coming back to our poll and what we talked about in that question, that was what was I think the viability testing was more appropriate. This is the PET scan on that patient. And as you guys can see, there is a large, severe resting perfusion defect extending from the base all the way base to the apex of the inferior infralateral infroseptal walls. And there is no FTG uptake here. So hence it's a lot of RCA and the circumflex territory scar, and a small severe resting apical perfusion defect as well. Severely enlarged heart size, severely depressed LVEF. So based on this, we have been medically managing this patient. and have not taken him for revascularization at this time. If there are no questions, then thank you, everyone. Thank you for attending.